Hi, good evening, everybody. Welcome. Thank you to everybody for joining us. We're really excited to be bringing this webinar to you. I'm Helen. I'm here from Action Duchenne. I'm only introducing. You won't be hearing too much from me, don't worry. But just a little quick bit of housekeeping before we start. You'll have noticed as you joined that we muted your microphones. Just to keep all the background noise. If you do need to be doing things in the background, you're free to sort of come and go as you please, and you won't be disturbing anything. You'll see, or you may have already seen, there's a chat box on the right hand side. So we'll be inviting any questions you've got, feel free to pop in there throughout the presentation. The way that we'll work is probably James will keep an eye on it and answer questions that are maybe about clarifying about what he's actually saying at that moment in time. And then towards the end, that's when we'll be collating all the questions, and we'll go over all of the questions that you've asked throughout the session. So do add them in as you think of them rather than saving them up to the end, just to make sure that we get everybody in. Sam and Lynette are working very hard in the background, so they'll be taking your questions as you write them and make sure that we've got everything covered. Some of you will have heard, I said at the start, if you feel comfortable with your camera on, feel free to leave it on. If you prefer not to, that's absolutely fine. We are recording the session, so we will be releasing it to the community. So if anybody feels uncomfortable in any way, please feel free to switch your cameras off, your microphones off anywhere. And if you did feel less comfortable and wanted to leave, that's absolutely fine. We will distribute the recording anywhere. So without further ado, I'm very happy to introduce Dr. James Poysky. James is a clinical psychologist. For anybody who doesn't know, he's internationally recognised and expert in the field of muscular dystrophy. Just as important as that, he's a dad. He's got his own son is living with Duchenne, and he's a familiar face, a very good friend of Action Duchenne. Almost always at our international conference, and we love having him. His session is always absolutely packed to the rafters, and the feedback from last year was that there wasn't enough time, and so that's what really prompted us to put this webinar on, to really give time to James to present, but also plenty of time for people to ask questions, and really hope that all your questions can be answered tonight. So without any further ado, over to you, James. Thank you.
Yep. Can you guys hear me? Can you hear me?
Yes.
Okay, good. Sorry. Want to make sure I had everything right. And I'd just like to thank our sponsors for today, which are CVS sanitary hand wipes and Germ-X hand sanitizer, which they say apparently you can go places and touch things unless you're in a government mandated lockdown. So anyway, take that for what it's worth. We can take our time today. As soon as I'm done with this, that means I have to go home to my kids who are probably tearing the place apart. So, please ask lots of questions. We can drag it out as long as possible. That would really work well for me. Anyway, as was mentioned previously, if you have any questions about what I'm talking about, like if something isn't clear or something didn't make sense, or you didn't hear what I said, please post a question or let me know while we're talking. However, if you have questions more specific to your circumstances, or if you have a question about a specific situation that you've experienced, those kinds of questions might be better saved to the end, when we can have more kind of like a rolling discussion about those sorts of things. Just for sake of getting through the presentation first. But please jump in if something isn't clear or you have questions, and then we can address kind of clinically related things later on. And as was mentioned, I have a son who's 17 who has Duchenne, and I also have a 12-year-old daughter who she's very sweet, and he's the high maintenance one. I love him to death, but he's a handful. So I've experienced this stuff not just as a professional, but as a parent too, which I don't think it necessarily makes me a better parent being a psychologist, but certainly probably makes me a better psychologist because I've been in the trenches myself. You guys can't obviously see this, but the skies are getting really dark right now here in Texas, and it's only about 3 p.m. We do get thunderstorms here that can be pretty bad sometimes. So if for some reason the power goes out, we can like find another day to finish up if we have to. But anyway, sorry, I've been babbling on here. Today I'm going to be talking about learning problems and neurobehavioral problems that can happen in Duchenne. And this is an area that I certainly have a personal and professional interest in, but it's something also that I've found can cause a lot of stress and difficulty and discouragement, and can really have a big impact on families, and is often overlooked in terms of services that are provided, or just even acknowledging that this stuff is an issue when people go to clinic. So it's near and dear to my heart, and we'll be kind of going over some of the main things to think about. And if you want to do the next slide, Lynette. Perfect. So actually, if you can scroll down just yeah, no, that's good. So I'm going to first briefly go over some of the different things that can contribute to some of the learning and behavior problems that we see in people with Duchenne. And then we're going to talk about kind of some of the main things to look for as far as red flags, or what it looks like, how it might kind of appear on a day-to-day basis. And those will include things related to kind of general areas of weakness or problem solving, but then we're going to also talk about more kind of specific conditions or kind of disorders, if you will. I don't necessarily like that term, but diagnoses, just as a way to kind of conceptualize this stuff. And then we're going to talk about some different things to help with this. And the examples the advice and interventions, the advice about interventions and treatments is going to be a little bit non-specific. I mean, I'll talk about things to try, but it may not be kind of as detailed as some people want, and that's kind of, it's because it can be complicated and there can be a lot of things to cover. But that's where maybe more kind of, if people have more specific questions about kind of what to do in different situations, that's where we can answer those kinds of questions just kind of during general discussion. But I'll kind of go over the basics in terms of general approaches. All right, next slide. So when you're talking about the kinds of learning and behavior problems that can occur in Duchenne, they're actually the same kinds of learning and behavior problems that can occur in people without Duchenne, but it can be more complicated. There can be more factors that can contribute in any given situation to what's happening. And certainly one of the main things that jumps to people's mind is, well, somebody might be having difficulty because they're just having a hard time with Duchenne and coping with Duchenne and adjusting to Duchenne, which certainly is a valid point. We find that doesn't explain everything. There's other factors as well. Certainly there are what we call psychosocial factors, which are kind of like socially related factors. So parent stress can be a big one. I found that kids can kind of be barometers to parent stress, and they kind of soak it up and may kind of magnify things if there's anything going on. Certainly, if there's other things going on at school, that can contribute to someone's level of distress and acting out or learning difficulties. There's other medical factors too, such as steroids. We know that can kind of crank things up for some people. But also if you're feeling tired all the time, or let's say you have sleep apnea and you're not getting good rest. My wife's not here, but she would be the first one to tell you that if I don't get good sleep, I get a little bit grouchy. Just a little bit. And also things like low blood sugar can play a role. But one of the things that is most often overlooked is now we have a lot of evidence that suggests that the problems that we see in Duchenne can actually, for some people, be related to brain functioning or not functioning as well as it should. And there is some research that's emerging that is starting to demonstrate that. And we have it hasn't been looked at anywhere near as much as the research that's been done looking at the physical side of things or the muscular side of things. But we do have some indication that dystrophin absence or deficit can also impact your brain as well. And so if you want to do the next slide, Lynette. And can everybody see the slides, by the way? Because somebody just indicated that they couldn't see the slides. I don't know. I'll just keep going. All right. So
I'm sorry, James. I just had to unmute myself then. I'm struggling to, some people are saying they can see the slides and some can't. So
Okay.
I'm just trying in the background to figure it out at the moment, if that's okay. Sorry.
I'll pause for 30 seconds. Yeah, or let me know.
Someone said they can, so that's okay. So I think I've got 2 people that can, 1 that can't. So I'm just going to work it out. So you carry on, and I'll
Okay.
well, everybody can see, so that's okay. I'll try and work it out. Thank you, James. Sorry, everybody.
Sure. Yeah, no problem. Okay, so dystrophin, as we know, I'm sure people have probably heard something about the dystrophin protein before, and have probably, I'm hoping, been to conferences or at least read things or viewed things that have given them some kind of idea about the protein. But it's a really big protein, and there's a number of different important elements to it. And the full-length dystrophin protein, which everybody should have, it is found in the brain, not just in the muscles, but also in the brain in a number of different areas. And it's found in like the cerebral cortex, which is just kind of like the overall wrinkly part on top and kind of tucked in on the sides. But also the hippocampus, which can be an important area for memory, but also the cerebellum, which is kind of like the little kind of small extra wrinkly part in the back. And also we see that it seems to play a role in and be particularly clustered around GABA neurons, which GABA neurons are some of the main neurons in your brain that basically put the brakes on, calm things down, inhibit things. And, you know, I think that certainly is telling, given that kind of some of the other things that we'll talk about. But there also seems to be other aspects or other neurotransmitters that it seems to associate with as well, to a lesser extent. And if you want to do the next slide, Lynette. Now, based on where your child's mutation is, there are smaller versions of dystrophin that are typically made as well. But depending on where the mutation is, those smaller versions may or may not be present. So obviously everybody is missing the full length. Everybody who has Duchenne is missing the full length dystrophin protein. But you may be making some smaller versions that are in the brain. One is DP140, DP116, which actually we don't think necessarily plays much of a role, but also DP71. And these are much smaller versions. They're found in the brain, and we're less sure kind of what they do. And for DP140, and I'll kind of talk about this later on in a second, but DP140 is a smaller version, and the promoter or basically the part of the gene that initiates its production is located between exons 44 and 45, which I don't know if people have talked about this in the past, but that's a common break point. That's a common point of mutation. Now, the actual protein itself starts at exon 51, which is also a common mutation point. And so DP140 is one of the smaller versions that can also commonly be affected in Duchenne. Mutations with DP71 are quite rare, but they can happen as well. Now, if you want to move to the next slide, Lynette. Oops, hold on, sorry, I closed the comments. Okay, so in general, what does dystrophin do in the brain? Well, like I said, there hasn't been a lot of research, but there is some indication that indicates or that shows us that dystrophin helps the ion channels, or it basically helps the part of the neuron that transmit electrical signals. It helps it be in the right spot and localize in the correct place and cluster in the right places. Because you do have to have them more in certain spots than in others. And if it's kind of not strategically located, then the electrical impulse that travels along the neuron is not as efficient, and the neuron's ability to recover from that is altered as well. And so there is some indication that without having that, neurons don't function as well as they should. There's also some indication that there may be some very subtle alterations in the size and shape of certain neurons. There seems to be less connections, or what we call dendritic branching. It's not an overt sort of difference. It's like if you were to scan someone's brain with Duchenne, it wouldn't kind of, in a general sense, look all that different. But there have been some studies that have shown that people's brain with Duchenne, or people who have Duchenne, that their brain actually does have some differences in functioning in terms of metabolizing glucose and possibly some blood flow as well. There's also some indication that there's differences in density. There haven't been a lot of studies looking at these things, but given the fact that there's only been a few, but they're indicating some differences, I think that that's certainly telling. And if you want to do the next slide, Lynette. Now, it looks like there's also some evidence that indicates that if you're also missing one of these smaller versions of these smaller isoforms of dystrophin, it really increases your risk of having some learning and behavior problems. And the one that's been most implicated is DP140, which is a smaller, like I said, the smaller version. Now, DP140 actually, it's a little bit different than the full-length dystrophin protein because it is present in the brain during pregnancy, in the fetal brain. But after somebody's born, it largely shuts off. And then kind of the full-length dystrophin protein takes over. And so we're not sure exactly why missing this increases the chance of having some learning and behavior problems. People have speculated different things. Some people think that maybe, if you're missing the full-length one, maybe if you have the smaller version, it can kind of compensate initially for that missing larger protein, especially during important stages of brain development. But I don't think we can really say why that's the case. But it certainly is an increased risk factor. Now, people who have who are missing DP70, which is like the tiniest version, which basically they're not making any dystrophin product really, those people are at the greatest risk for like really significant developmental delays and cognitive delays. Now, it's hard to, again, to say exactly what role that plays. There may be something about DP71 helps water channels form in the brain in the correct places. But we're not really sure. All we can say is that it certainly is an increased risk factor, and I think more investigation is needed. However, at the same time, we do have clear evidence that neurologically there's something going on beyond just kind of muscle functioning. And if you want to go to the next slide, Lynette. We're not sure exactly what is going on, but we do have enough evidence to say now that there's a role there. And it's not just because of, people aren't having problems just because of bad parenting or because they're upset that they have Duchenne or, some explanation like that. Like clearly there's a neurological link. And it's surprising, I just kind of gave you a quick summary. There is a lot. Well, I don't say a lot. There is more information than I summarized here as far as the neurological connection, but I still run across people, probably less common in the UK and less common in the US, but in other countries, I still run across people who tell me that, yet their doctor tells them with 100% conviction that there's absolutely no neurological role in Duchenne, which just kind of flabbergasts me. So take that for what it's worth. All right, we can move on from there. So in terms of learning problems are more common in Duchenne than in the general population. And this was just a random sampling of families as far as being part of a database collection project. Actually, I wasn't involved in the asking, I was more involved in the analyzing the results, but they had asked people, do you have any concerns about learning? And it was a vague, non-specific question. And the response that they got back was about a third of people had reported that they had concerns. And some of those had received a kind of an official diagnosis of a learning disorder. Others had not. There was kind of more general concerns. Frankly, I was surprised about the number of people who didn't report concerns. My experience has been that it's probably more common than what's necessarily this is indicated. However, I think it's something that we can't ignore. If you talk about kind of general learning problems in the general population, like learning disorders in the general population, Estimates vary, but people think that probably about maybe 8 to 13% of people have a learning disorder, whereas in this case, there's suggestion that it's certainly much higher than that. So if you want to move to the next slide, Lynette. So there are some problem areas that can interfere with learning that aren't necessarily what we would call a learning disorder. These are other kinds of cognitive skills or processing skills that aren't kind of specific to one academic subject, but they can still get in the way when it comes to learning. And one thing that people have looked at is overall IQ, intelligence. And IQ people can't really agree what IQ means. IQ tests are not necessarily that great a measure of IQ, ironically enough. However, we do find that IQ tests can be a good predictor of academic outcome, or a relatively good predictor of academic outcome. But you have to take it with a grain of salt as far as what it all actually means. But there has been some indication that there's a broad range of findings when it comes to intelligence in people who have Duchenne. And similar to the general population, there's some people that are really brilliant. There's some people that are above average. Most people are kind of in the average range. And then there's some people that are below average. So it can be a broad spectrum. However, we do find that there's some indication that more people might fall below average than we would typically see in the general population. Now, it's hard to say exactly how accurate this is because initially some of the studies that came out looked at people who were institutionalized. This was from a number of years ago. That may be different now, or if you look at people who aren't necessarily institutionalized. There is some indication, though, that a weakness in language development or language skills, which I'll talk about more in a second, but a weakness in that area may pull down an overall IQ score because IQ tests look at a number of different kinds of areas or different kinds of problem solving. Then they average them together into one kind of overall final score. And if you have a weakness in one area, it's going to pull down that overall score, even though you might have strengths in other areas. And there's some indication that the verbal IQ pulls down that overall IQ, whereas the visual IQ, so like identifying patterns, how things fit together, kind of more stuff that maybe like an architect or an engineer would use, spatially anyway, not the math necessarily, but those kinds of tests are more kind of typically distributed, which means that you have kind of the same number of people in the normal range as you would people who don't have Duchenne. So anyway, moving on. It is a true finding, or it is a true kind of conclusion that there is an increased risk of having a delay in language development or having problems with language processing when people have Duchenne. And I can't remember the exact estimate, but off the top of my head, I want to say that I think up to a third of, maybe even 40% of preschool aged kids with Duchenne have a delay in their language development. And actually, there was a big push a number of years ago to have creatine kinase testing kind of done routinely whenever kids presented with a language disorder, just because of the frequency of that. We do see where there can be some improvement as they get older. So they do make some gains in catching up. They don't always necessarily catch all the way up. And in general, sometimes language can kind of continue to be an area of weakness, but it does seem to improve. Now, it's a little more complex than that, or a little bit more nuanced than that, in the sense that we see where vocabulary, which is basically how many words kids know and the meaning of those words, that tends to be in the normal range. However, they can have more difficulty with language comprehension if you give them too much at once. So if you hit them with too much, they can kind of get overwhelmed in their ability to kind of interpret what that all means. But also kind of the more conditional or complex the language is, the more kind of if then or this that sorts of comparisons, they can kind of get overwhelmed and kind of lose the main idea. Similarly, they can have difficulty following more than one step. If you hit them, kind of like I said before, with too much, it's kind of like they lose it. They can also have some problems with verbal fluency, which is being able to quickly and accurately explain what they're thinking, describe things. And so we see sometimes their explanations can be more kind of choppy or slower, Sometimes they can have word finding difficulties, which is kind of like thinking of the, we went to the store. Oops, sorry, I have to just close this down here. And so they can have difficulty getting words out. And it's not unusual to see where they can really have a lot of difficulty relating a sequence of events. And so, I can't tell you how many times something happened at school. My son comes home and he's upset, and we can't get a straight story out of him about what happened. And like we get 10 different versions and we're still not sure what happened. And so they can have a hard time kind of organizing those thoughts and kind of expressing them in a way that is kind of clear and coherent and logical in its sequencing. Okay, Lynette, do you want to move to the next one? We can also see where people with Duchenne, kind of regardless of their language development or regardless of their overall intellectual ability, they can have problems with short-term memory. And in particular, we have a fancy word for it. We call it working memory. Working memory is being able to take new information in and then step back, kind of reorganize it without forgetting it, or being able to take new information in, step back and analyze it without losing it. And we can see where they can have a lot of difficulty with this. And so I'll give you an idea of what working memory might look like. So if I told you, I want you to go to the store and I want you to buy toilet paper, paper towels, hand sanitizer, sugar, milk, and lots of beer, short-term memory would be remembering that list all the way to the store. Working memory would be once you dodge the security guard and cut in front of the line and get inside, you actually go to the hand sanitizer first, even though that's not at the top of the list. But that's most efficient when you're working your way through the store and you're able to kind of reorganize it, but not forget it as you're getting your different items. But a lot of learning requires both short-term memory and working memory. In particular, things like word problems in math. You have to keep all that information in mind and be able to step back and kind of think through it without losing it or losing the important details. Okay, Lynette? As I'd mentioned before, there are kind of some general things that can get in the way of learning, but there's also an increased risk for having a specific learning disorder. And a specific learning disorder is basically where you have difficulty learning a specific area of basic academic skills, and it's either in reading, writing, or math, despite having, otherwise normal abilities. And dyslexia is the scientific term for a learning disorder in reading. Dyscalculia sounds fancy, but it's a problem with math. And dysgraphia, which a lot of people probably heard of, it's difficulty with writing. And I'll talk more about these specifically as I'm going on. But Lynette, do you want to go ahead and go to the next one? So one of the more common ones that we can run across is dyslexia. And there's a couple of really bad research studies back in the 80s, which made everyone think that dyslexia is a visual problem, that people see letters backwards or reversed or moving around on the page or that sort of thing. But we now know we have a lot of research that shows that's really not the case. They can see the letters just fine. The problem is more with the sound aspect and matching the right sounds up with what they're seeing. And so we see where early on in kindergarten, most kids in preschool, I don't know what you would call it in the UK, but in preschool, which is like schooling when you're 3 and 4 years old and kind of early 5, before you really start primary school, they spend a lot of time, or they should spend a lot of time, playing sound games, like rhyming games and clapping sounds and identifying beginning sounds. All of that is an effort to help promote the development of sound awareness, or what we call phonological processing. And you have to develop early on an understanding that language is made up of different sounds that we put together in order to then learn basic reading skills. Because again, you have to see a letter and then pull out the right sound and match it up with what you're seeing, or being able to look at multiple letters and break it down into the right sounds and blend them together to make a word. So you've all probably heard of the term phonics before, and that's what that process is being able to sound out a word and blend the sounds together. And so dyslexia at its core is really a problem with phonics. And, you know, as you start to learn to read, first of all, you have to match up the right name and the right sound with individual letters, but then you have to learn to recognize letter groups, and then syllables, and then eventually complete words in kind of a sequential process. But then also you have to become automatic at that process. And so we see problems with reading early on in milder cases as far as just learning letter names and letter sounds, or we can see problems with sounding out basic words. But we can also see milder cases where the accuracy might not be bad, but they don't develop automaticity, which means it continues to be laborious and effortful, and it doesn't just kind of click automatically. So if you want to do the next slide, Lynette. The telltale signs of dyslexia, like I mentioned before, is difficulty learning letter names or letter sounds. Sounding out words is tough. They may just look at the first few letters and guess at the rest of the word, or drop word endings, or kind of, you know, make careless mistakes. They may add words in there that aren't there, which means they're trying to overly rely on their language skills rather than their word decoding skills. We can see problems with spelling also. In part, you know, if reading is sound decoding, spelling is sound encoding. And if you have a problem with those sounds, it's going to hit you both ways. Some kids, we see a lot of problems with reading fluency, which means their reading is kind of laborious and choppy, and it doesn't kind of flow easily. Then obviously, if you're having difficulty decoding words at the basic level, or if your fluency is poor, it's going to affect your comprehension, because it's hard to kind of step back and think about what you're reading if you're exerting so much effort decoding the basic words. And these are the kids that I always ask them, do you like reading? And they always say, I hate reading. And then I ask them, this isn't completely accurate. I mean, it's not always completely accurate assessment, but I ask them, do you hate reading because it's boring, or because it's hard, or because it's both? And the kids with attention problems, they tell me they hate it because it's boring. The ones with dyslexia either tell me they hate it because it's hard, or because it's hard and boring. So anyway, next one. So dyscalculia is problems with mathematics. And in general, not specific to Duchenne, but just in general, there's a lot of research that's been done looking at dyslexia. But dyscalculia, there's not really been or it hasn't been as much done. And so this is probably one of the learning disorders that we know least about, as far as kind of what it looks like and what causes it. And there's some theories out there, but it's been really hard for people to prove them. But I'm kind of breaking it down this way, just kind of as a way to kind of understand it. But keep in mind, you could talk to someone else and they totally disagree with me. But in general, the way I view it is there's kind of three main areas of mathematics that people can have difficulty in. And one area is difficulty understanding math concepts or having number sense, which basically means kind of getting the gist of it. So this could mean being able to estimate value. And so if I do my math problem and I get an answer, if I do 25 times 10 and I get 3,572,000, I mean, I might not know what the right answer is, but I can eyeball it and tell that I got it wrong. People who have difficulty in this area can't really do that. They don't really have kind of like a frame of reference, really. They also have difficulty understanding abstract concepts such as percentages and fractions and decimals. They're all the same thing, but just represented in different ways. We can also see where they tend to have difficulty visualizing information, like from a word problem. There does tend to be a fair amount of visualization that's required in terms of kind of picturing it in your head, either spatially or kind of like, you know, in terms of direct interpretation. But we find that they have a hard time doing that. And so word problems in particular can cause difficulty because they're not sure what kind of operation to use. They don't really kind of understand the concepts of altogether, or what's another key term? You know, how many are left? Those sorts of things kind of goes over their heads. Another area is difficulty with math operations. So this is basically remembering the steps when I'm doing arithmetic problems. Which side do I start from? How do I line my numbers up? You know, how do I borrow? Which direction do I go? kind of the procedural aspect of it. This is also probably related to being able to have an internal number line. So if you have to count backwards, being able to kind of picture it in your head and then kind of count backwards visually. The third area can be difficulty memorizing math facts. And so they don't develop automaticity for the addition table or multiplication table. And there's a lot of like counting on their heads, they have to, or on their hands and toes. They have to use a calculator. And they don't develop that automaticity, which definitely, you know, gets in the way of doing the more complicated stuff. The third area is dysgraphia. And dysgraphia is a term that people use in a variety of different ways, and not everybody means the same thing when they say dysgraphia. So I've included all these three ways together, but if you hear someone else say it, they may not necessarily be referencing all of these areas. So just kind of keep that in mind. Most commonly, dysgraphia, the term dysgraphia is used to represent problems with the fine motor aspect of writing, as far as like letter formation, pencil control, basically handwriting legibility. And kids who have problems with this have difficulty remembering how to form letters early on. So sometimes they'll start writing letters in unconventional places, like if they're drawing a T, they'll start at the bottom and go up and then do a cross. Things like that. Maybe it's not the best example, but they also have difficulty with sizing and spacing. So they may push all of their letters together, or they're all different sizes. They may have difficulty remembering how to form a letter. So they'll throw an uppercase letter in the middle of a word just because they can't remember the lowercase letter. Also, and most of the time they can write, but it's a lot more laborious for them and it's slower. And so the writing doesn't flow. And it takes a lot more effort to make the pencil go where they want it to go. And so it can cause a lot of frustration just in terms of speed. And they complain that their hand hurts and that sort of thing. Another area is difficulty with the mechanics of writing, basically things like grammar, punctuation, capitalization, as far as understanding where it should go and when to use it. Grammar, that can be tough. Sometimes that's more related to a problem with their language development, and it's not specific just to writing. The third area, and this is the area that I run across a lot, but I find that this is overlooked often. Third area is with basically thinking of what to say. We call it ideation, which is generating ideas, sequencing ideas. And this shows up, well, it can show up in the early years, but it's a particular problem later on when the writing demands increase. This shows up most often when the writing task is open-ended and unstructured, and they have to kind of come up with it on their own. And so these are kids who will kind of stare at a blank page and just don't know what to say. And they say, I can't think of anything. And it's true, they are having a hard time with that. Sometimes it's interpreted though as being oppositional or, you know, refusing to try, but there's more to it than that. And so, you know, kids like this, you say, I'd like you to write 3 sentences about your summer vacation or your summer holiday. And it's like pulling teeth to get anything out of them because they don't know, and they're asking for help, and then they get upset, and it takes an hour to get 3 sentences. It's even magnified later on when they have to write an essay or something like that. And it can just be overload. So Lynette, if you want to move to the next one. Aside from specific symptom or specific signs of it, there's also general signs that we look for when kids might have a learning disorder. And this is basically where you're seeing a lot of anxiety when it's time to do blank, like get out your reading homework and they fall apart, but they're excited about math. It's also when you see significant differences across subject areas. And it's not just kind of one's a strength and the other's not, but like really significant differences. And we get A's when we do math, but we're failing reading and writing because it's just too hard for us. And again, kind of like I mentioned before, if you're having meltdowns when it's time to do something, that could be a sign. If they're saying, I absolutely hate this, or I'm terrible at this, that can also kind of be an indirect sign as well. So those are things to look for. And Lynette, if you want to go to the next one. So the next section I'm going to talk about, these are things that we call neurobehavioral disorders. And this is basically a fancy way of saying that these are behavioral or emotional problems that happen because of how the brain is functioning. These aren't things that are necessarily happening because of bad parenting or other things like that. These are like really neurologically based, where there's some sort of kind of dysfunction in neurologically speaking that is causing these things to happen. And one of the most common things that we run across is ADHD, or attention deficit hyperactivity disorder. There used to be attention deficit disorder, but they got rid of that about 15 years ago. And now they say everybody's ADHD, but there's different kinds. And I don't know why they did that. It just confuses everybody. But anyway, you have some kids who have problems more with attention. You have some kids who have problems more with like impulsivity, or you have some kids who have kind of a combination of both, or it might look one way in one situation and a different way in another situation. So there can be some variability. But what I want to point out is two things. Especially in DMD, you can have kids who have this who aren't hyperactive because of the physical limitations of the disease. You're more likely to see problems with impulsivity, blurting things out, interrupting, impatient, not knowing when enough is enough, emotionally reactive, just kind of have a harder time calming themselves and putting the brakes on. Like the filter doesn't work as well. Also, when people have attention problems, they pay really good attention when things are interesting. Really, what we look for is how well do they pay attention when something's not interesting? And that's really where it gets you, and that's where it shows up. And I mean, all of us to some extent have a hard time paying attention when it's not interesting. But to a certain extent, you have to be able to force yourself to pay attention when you need to, even though you don't like it. And that's the distinction that we see. We actually see people with attention problems, they get over-focused on things of interest, on fun things. Like I have yet to see a boy with attention problems who couldn't play Fortnite for like 5 hours, no problem, right? But you pull out that math homework and watch it tank instantly. So the problem is it's much more externally dependent. It's dependent on what's right in front of them in terms of their motivation and their effort. It's more all or nothing. And they have a harder time sustaining that in situations where where it's not fun, or there isn't some, kind of immediate reward or perceived benefit. And they have a really hard time making connection between hard work now and long-term payoff or long-term benefit. And so you can see a lot of procrastination. They would complain about something longer than it would take just to get it done. They also can have a tendency to be distracted easily. They can be forgetful, absent-minded. You'll tell them something, they'll go into the next room and they forgot what you just said. Disorganization can be an issue. Planning ahead can be a problem, especially if they have to like take a task and break it down into the steps. They can have a hard time knowing where to start. We can see some spacing out and daydreaming, but I don't see that as much when people have Duchenne. It's more like the work avoidance tends to be kind of the biggest factor that I tend to see. So Lynette, if you want to go to the next one. So these are kids who have problems with being argumentative, oppositional, contrary. It's kind of like their automatic reaction is no, or they're freaking out all the time and having meltdowns, angry outbursts, kind of lashing out at their siblings or being critical over the littlest things, despite, you can't handle it if they're criticized for the same kinds of things. And you can go ahead and switch to the next two slides, Lynette. I don't want to like name any names, but there may be people in the public sphere that, you can move on to the next one. I didn't mean for him to come up. He's busy right now dealing with the coronavirus. But these are kids where it's like they don't seem to learn their lesson. And this is a sort of situation where it's kind of like once they start down a path, once they kind of get their mind set on something, you can't convince them otherwise, even when it's like totally irrational. And they have a hard time being flexible in response to feedback that they get or kind of changes in circumstances. And they'll kind of get their mind set on something. They'll start kind of going down that path, and then they'll get stuck. They can't like move on if it doesn't turn out the way they wanted or expected. It's like they can't kind of problem solve it and kind of adjust. It's like they keep kind of ramming into it and just can't kind of adjust. These are also kids where you tell them that, so you might say, hey, you need to stop what you're doing. If you don't stop, here's what's going to happen to you. and then they don't stop and they end up getting in trouble, and then they're like surprised and mad about the punishment, even though you told them exactly what would happen. And then they start acting up, and then you impose a bigger punishment on them, and then they start acting out even more. It's like they can't step back and say to themselves, oh, I don't like this, but if I keep doing this, I'm going to be even more unhappy. They're very much caught up in the moment, and these are kids where punishment escalates things and things spiral out of control, and they don't seem to learn their lesson. And it feels like it's purposeful. It feels like a power struggle, but really there's, the way we view it now is that they actually have weaknesses in their ability to be flexible in their thought process, and trying to force that by winning the battle with them doesn't make them more flexible. In fact, what happens is it makes people kind of more resentful and antagonistic and that sort of thing. So if especially, I throw this out there to dads, because we have a tendency to feel like we always have to win the battle. With kids like this, you can't. Well, maybe temporarily you can, but in a general sense, battling with them is not going to make them more flexible, and you have to approach it differently. So next one. It does look like there's some increased risk of autism in people who have Duchenne. And some of the hallmark features are a delay in language development. We can also see like obsessive or like really unusual in terms of like the topic or intensity, obsessive interests. There can be a really strong adherence to routine. There can also be like some excessive sensitivities to sensory things like clothing or textures or noises. Now, all of those things, to a lesser extent probably, can be problematic in other situations too. And I see a number of kids where they have some of these things, but it's not to the extent that we necessarily see when people have like full-blown autism. But there's maybe some kids who are kind of in a gray area where they got some tendencies, but maybe not necessarily kind of what would fit, your traditional diagnostic kind of criteria. The most telling thing, though, that we look for, because like I said before, other problems can cause difficulties in those areas, but the main thing that we look for is really difficulty understanding social interactions. That's like the hallmark kind of core deficit when people have autism. And this is difficulty understanding kind of the back and forth nature of interactions when I'm interacting with someone. And so that includes the use of nonverbal communication. So, and I don't mean just showing my emotions, but actually like using facial expressions and gestures to communicate. So like giving funny looks or, rolling my eyes or raising my eyebrows with intent to communicate. Also, like I said before, they don't tend to use gestures in the same way, what we call like emphatic gestures or descriptive gestures if I'm describing something with my hands. We also see where they have difficulty understanding the back and forth nature of a conversation. So I say something, you say something in response, I build on the conversation and respond to what you said, but then add something, and then you respond and add something based on what I said, like that back and forth aspect of conversations. And there can be more of a tendency to kind of just lecture at people or not necessarily respond when someone says something to them. They can also have difficulty making inferences and understanding non-literal use of language. So like phrases of speech or kind of reading the room, as people say. And I don't know if I can think of a good example, but it's probably, I'm exaggerating to make a point. But if I said, oh, it's raining cats and dogs outside, understanding that I didn't literally mean cats and dogs are falling from the sky. Or if I said, oh man, I got stuck on the freeway today for an hour, it was a blast, knowing that I was really just being sarcastic. And those are kind of obvious examples, so that they may not be the best. It's usually kind of more subtle than that. But we also see where they don't tend to vary the inflection of their voice. So the rhythm and the intonation of their voice may be awkward, or it may not kind of match the context. So those are really kind of more hallmark features that we tend to look at. And I don't tend to see kids with DMD have autism. I don't see it occur as much as the higher estimates would indicate. But I do see kids definitely who have it. And I think there's probably a number of kids with Duchenne who don't meet full criteria, but have some flavors of it or kind of some tendencies. Lynette, you want to do the next one? One area that I think is really very much overlooked in Duchenne is the presence of anxiety. And if you remember before when I was talking about the neurological contribution of it, GABA neurons, or some of the main neurons that seem to be affected, they play a big role in controlling anxiety. And if those ones are not working as well, it makes sense that anxiety would be a common thing. And I see it a lot when I see people with Duchenne. However, it's been largely under-recognized or under-reported. And I think because people don't always necessarily know what anxiety looks like, especially in kids. And I think also in Duchenne, it tends to look a little bit different than what you would think. So it's not necessarily, I'm worried about something. I mean, it can be that, but not always. More often what we see is easily stressed, easily overwhelmed, easily thrown off, easily agitated. And their anxiety is actually more likely to come out as anger than it is, I'm worried about something. So it depends on how you define it, and it depends on how you're looking for it. But I think that this is a pretty common problem that we're really not doing enough about. Want to do the next one? The other area is social anxiety. And I see a lot of kids with Duchenne who really have a lot of anxiety and when it comes to social situations. And so this is feeling really nervous, like when you're around people or when you have to interact with people. And so what happens is they can be very shy, they can be withdrawn and quiet, like when they're with other people, but at home they will talk your ear off. These are kids where you might even say hi to them and they'll be like, hey, they might wave a little bit and then kind of look away. These are kids where you might, I see this all the time when I go to conferences, like I'm passing them in the hallway and I say, hey, John, and they just like stone face me. I'm like, dude, we were just talking a minute ago. Like, oh, okay, hey. That's what we see a lot. And, I think in part it's also probably neurologically based, but it's also probably a factor too of their experience as far as feeling like you look different, feeling like you kind of get a lot of unwanted attention sometimes. It makes them feel very self-conscious. But I think that there is also kind of a neurological role to this as well, that they're just kind of more wired towards having that predisposition. I see now, especially that the use of phones is so prevalent, I see that there's a tendency for them to use their electronics or their phone in a social situation as a means to not have to interact with people. Not necessarily because I'm bored, but like to purposefully as an escape route almost, and to avoid people coming up to them, because people don't tend to do that if you're busy on your phone or whatever. All right, next one. Obsessive compulsive disorder can also be one that we run across. This is probably another area where we don't see as many with full-blown OCD as maybe estimates indicate, but certainly there's a lot of people with kind of characteristics of it or tendencies without having kind of the full-blown type of presentation. True OCD, you tend to have extreme obsessions and compulsions that pop into your head that you view as unpleasant, that you don't like. Feels very uncomfortable. That's different than being obsessed with Fortnite or something like that, which is more kind of entertaining, or I like that. But we do see a lot of kids who have Duchenne who are very particular about things. Like things have to be just a certain way, and they have a really hard time tolerating if something isn't a certain way. But that thing may change from day to day or week to week or month to month. Whereas in true OCD, it tends to be a little more persistent pattern of the same thing over and over again. Okay, go ahead, next one. This is something I'm just going to mention real quick, but we do see, this is not in any research study I've seen, but I run across this a lot, where kids with Duchenne seem to be more sensitive to drops in blood sugar than other folks do. And if you were to test them, their glucose would probably still technically be in the normal range, but it's something about the drop. If the drop starts, they experience the effects of hypoglycemia, even though they don't technically have hypoglycemia, and they get mean and emotional and nasty. And if that's the case, like there's nothing you can do until you get some food into them. The problem is oftentimes, though, by the time they hit that point, they don't necessarily feel hungry. And so it can be a battle just to get them to eat something. And so, you might say, they're having a meltdown because, they're, let's see if I can think of a good example. They're having a meltdown because, you didn't write their assignment, the title of their assignment, just right. And you tell them you need to eat some food because you're getting hungry, and they're like, I'm not hungry. The problem is there's nothing you can do until you get something into them, and so sometimes you have to stay ahead of that and kind of get them before they hit that point. So how are we doing on time? Good? Okay.
We're okay. We're okay.
Okay. So in terms of the next section, I'm going to talk about different things that are out there that are available as far as helping out. And these all come from the treatment recommendations that were published in 2010 and then more recently. But the thing I tell people is there is stuff out there that's available. Like, because these problems that we see in Duchenne are the same problems that we see in people who don't have Duchenne, there are resources available and there's treatments available. There's all sorts of stuff. Now, it doesn't always fix everything 100%, but at least there's, I think, more options there than sometimes we feel like there is for the physical side of things. But don't wait. If you have any concerns about this stuff, the quicker you jump on things, the quicker you get help with this stuff, the better. Because if you can catch a problem when it's on the smaller side, then it hasn't kind of snowballed into something that's even bigger and more complicated. It can be hard to find mental health experts, though, who understand or know Duchenne. And, you know, if you can find one, that's awesome. But it can be tough. And so I think the main thing that you want to look for is somebody who's at least willing to learn about Duchenne, or maybe somebody who has experience working in mental health situations with people who have other kinds of medical conditions or chronic conditions. So, you know, the main thing, you're going to be the expert on this stuff. So you're going to have to educate them about Duchenne, and then hopefully you can kind of approach it kind of as a team. In terms of learning problems, I'm not going to get kind of into these things too much in depth because it's a whole nother topic. But in general, if a kid is having any difficulty in any area when it comes to learning, again, you want to jump in early and try to address that. You don't want to just kind of cross your fingers and hope they'll outgrow it and say, oh, he's a boy. Boys just take longer to learn how to read. Well, no, don't listen to stuff like that. You want to jump in with early intervention. We do have things that can help, especially with reading and writing. Math is a little bit tougher as far as to know what to do, but with reading, we're pretty good about fixing dyslexia if we catch it early enough. Can't always fix it, but we can about 80% of the time. So early intervention is key. For older kids, or maybe for kids who received intervention, but we still got some residual difficulties, there are ways you can get around it. There's things that you can do to help reduce the impact. And I'm not going to get into it a lot, but these are largely things that you would put in place as a part of their education plan. I think you guys have IEPs in England. I can't remember exactly what you call it, but I think it's the Senko who helps arrange that stuff. You know, they're not ideal always, but you know, it's a start and they can help. I always tell parents, and maybe this is more because the view in the skepticism that people have in the US with systems in general, but I always tell people you want to advocate and fight for as much help as you can get in the school, but you never leave it up to the school to fix everything. And so you always want to have a plan for in school as far as what you want to happen, but you also, if you can, want to have a plan for how you're going to try to address things outside of school. So you're hitting it from as many different directions as you can, whether that's learning or behavior or that sort of thing. You want a kind of multifaceted approach, just to kind of maximize the chance of success. Go ahead. So different kinds of evaluations. Evaluations are a good way to help clarify what's going on, as well as have documentation that substantiates what's happening, that clearly describes what's happening. And here in the US, we're probably more likely to have neuropsychologists. These are psychologists who have extra training in how the brain works. That's like what I do. If you may not have as much access to that in the UK, so maybe more like educational psychologists or school psychologists or somebody who could do those kinds of evaluations. Clinical psychologists also as well. Psychiatrists, they tend to mostly do medicine nowadays, so they may be kind of less involved in terms of like learning concerns, but they do diagnostic workups and then, you know, do treatment planning, you know, particularly in as much as that includes medication for any problems, but they can be a part of the team as well. I think that the thing that we see in Duchenne is that there's more likely to be multiple problem areas, and so that can make it more complex. And so an evaluation can help kind of tease those things apart. But like I said, be aggressive, get the help you need. If somebody kind of dismisses your concerns, go find someone else. Don't let someone tell you that you're just being an anxious parent and you need to just chill out and not worry about it. I hate when people say that. All right, next slide. I already kind of mentioned this, so I'm gonna skip past this. In the U.S., there's one thing though that I would say. So in the U.S., it varies from state to state as far as what kinds of educational programs are available. In general, special education is needed when you're actually having problems learning, not necessarily just because you have Duchenne. In fact, I see some kids with Duchenne who are brilliant and they don't need any educational help, but they might need some help with access or, making sure that their seating is appropriate or that sort of thing. So it really depends on what the child needs, less on kind of just because they have Duchenne. You really want to make sure that what they need is suited to what difficulty they're having or what their unique needs are, not just kind of like a blanket kind of rubber stamp for anybody who has Duchenne. It should really be individualized. Now, in terms of kind of more direct treatment, psychotherapy, or some people prefer the term counseling, it sounds less scary, I guess. That can be helpful for behavioral and emotional problems. For the kids who have problems with oppositional behavior and meltdowns and arguing, we find that direct one-on-one therapy with the therapist and the child doesn't tend to be super effective for that kind of approach. Usually what we get more benefit from is training parents to be the therapist at home and giving the parents different kind of techniques and strategies that they can use at home to help improve compliance and de-escalate outbursts and that sort of thing. Because we find that they, if you're talking to them in the clinic, when they're sitting on the couch, they can give you all the right answers. But like in the heat of the moment, when like it's all falling apart, it's not the same as sitting in the office. And so if you can help the parents know how to intervene in those most difficult times, that tends to be the best kind of learning process for the kid as far as coming up with other ways of dealing with those situations. Individual therapy, one-on-one with the therapist, that's probably helpful for things like anxiety and depression, OCD, coping with Duchenne. Group therapy can be helpful for like social skills deficits. And applied behavior analysis has been shown to be effective for some aspects of autism, but for it to be effective, it has to be pretty intense. And I don't know if you have that in the UK. We do have it here in the US, but you're talking like 40 hours a week of applied behavior analysis oftentimes. It can be really hard to get insurance companies to pay for it. I'm guessing it's probably hard for the NHS to get them to pay for it if it's available, but it can help. So I'll just throw that out there. Next slide. Medication is something that here in the US, we're probably a little bit too quick to go to. I think in the UK, people are too hesitant to go to. So, there's probably a happy medium somewhere in the middle, but, it's always something to consider. People have really strong reactions as far as, their take on medication when you bring it up. Most of the horror stories that you've heard are not true or not representative of most people's experiences. It shouldn't be used as an easy fix, shouldn't be used as an excuse to kind of not do anything else, but it can help a lot of kids, especially when it's part of a more overall kind of comprehensive approach as far as how we're addressing this stuff. In particular, ADHD symptoms and anxiety, those are the two things that I find that can get in the way the most, but medicine can go a long way in kind of helping with those things. Doesn't fix everything, but it can help. Next slide. I think Dr. Schoenfeld had previously talked about, talking with your kids about Duchenne and other people as well. And it is really important as far as helping people cope with Duchenne. They have to have information, they have to be able to talk about it. But it's also kind of the prerequisite towards helping them be independent. And we see that people tend to cope best in situations when they have more independence, when their ability to kind of do life activities is as close to air quotes normal as possible. The more things deviate from that, the more things, the more where we're kind of disrupting life, that makes it harder. And so, talking about Duchenne and having expectations for independence and, doing well in school and having a job and all that sort of thing as much as possible are important for helping with coping. One other thing I'm going to mention, this is a weird time right now, and I'm not sure what to make of it. I think I was sharing earlier with the other ladies before everyone jumped on board that, here in Houston, we have hurricanes, right? And, what happens when a hurricane is approaching is they'll either tell you to shelter in place and hunker down and don't leave your house, or they'll tell you to escape and flee the city. They've had a few times where traffic jams have been so massive on freeways that people have died in their car trying to flee a hurricane. So now most of the time they tell people just stay in place and don't move. And during that time, it's hard to know what to do. And usually what we do is we sit and we watch TV all day and we watch the storm on the television, like slowly approaching, and you can feel it coming and it's going to be tough, but you don't know exactly what is going to happen and what the future is going to hold as far as how bad it's going to be and how long it's going to last and kind of what's going to be there afterwards. And we're kind of in that scenario right now, and it can be tough as far as the disruption that this is causing. And if there's, I'm not an expert in this, but if I can give a few words of advice, the first one is don't feel like you have to be the perfect parent and you have to have the perfect setup at home and the perfect parenting setup in this sort of situation. My wife and I just shoot for good enough. Halfway, moderately average is like a goal that we shoot for, and sometimes we don't even hit that. But don't put too much pressure on yourself to feel like you have to be like the homeschool queen or king and you're gonna educate the crap out of them. Don't worry about that. You just want to shoot for good enough and set realistic, set some goals, but make sure they're realistic goals for each day. Also, it's important to treat it like you would any other day, in the sense of you want a daily routine as much as you can. You want to get up, get ready, like shower, dress appropriately. It feels kind of like a novelty to think about, I'm going to do homeschool in my pajamas. It's going to be so cute. Don't. You want to try to find a normal routine as much as you can. Also, you want to try to come up with a schedule as much as you can for the kids. It's okay to do some fun stuff, but don't mix it up too much. Try to come up with something that you can kind of replicate it each day. It's okay, though, to give them some control over that. So you might make a list of things that we have to do today, but you can pick when we're going to do it. Or, we're going to make a picture schedule, and here's the things that need to go into the schedule, but you're going to kind of put each one with, we're going to put some tape on the backside, and we're going to make a schedule what has to happen each day. But I'm going to put these two, and then you can decide where the rest go. So it's clear what has to happen. It's clear when it's going to happen, but they have some input into how to do that. You're going to have a lot of kids who are stressed out because the routine is off, just, the disruption from how things would usually be. But you can also have kids who are stressed out because they see parents are stressed, or they see that, they're hearing a lot from the news, from the TV. So it is important to give them an explanation of what's happening, but don't let them have unfettered access to information. Limit the amount of TV that they hear, the news, the broadcasters, the discussions that they hear, but still communicate with them about what's happening. Like, don't try to keep it secret, or don't try to kind of hide things from them. So, be honest, explain what's happening, but also limit things so it doesn't feel like it's overload. Because the way that kids often interpret that is, they may work it up into something even worse than what it already is. So, I think too, as much as you can, have some responsibilities that kids have to do, and also get them to help you in some responsibilities as well. You can be mom's helper for today, or that sort of thing. We don't want to kind of, we don't want to kind of tell them that this is such a weird sort of or different situation that I'm not going to expect anything of you. That's not actually good for helping them kind of cope with the situation. So maybe a chore or two or something like that would be good. It's okay to give rewards in situations like this in terms of if they follow through what they're supposed to do, if they follow the schedule. It's okay to use rewards. Don't overdo it though. And also, you have to wait till they get it done before you give the reward. If they tell you that, you know, if you give me the reward now, I promise I'll do it later, they won't. So don't fall for that. Sometimes you have to kind of be a little bit hard-nosed about that. But using rewards and setting goals is helpful, even just on a day-to-day basis, because it gives them something to shoot for, but it also helps them know when they reach the end. It's easier for them to hang in there if there's a light at the end of the tunnel, if that makes sense. I don't know. I'll leave it at that. The last page, Lynette, if you don't mind moving on. These are just some different resource guides. The one that Janet Hoskin wrote, I think, is a good kind of relatively recent one. I do have to make a financial disclosure. I do have a financial interest in this book. I got 2 free copies. So, you know, full disclosure, although I lost one of them, so I don't know where it's at. But anyway, that's pretty much it from my perspective. I guess if we move to the questions now.
Sorry, James. Hi.
Yep.
Thank you so much. Thank you.
Yep.
Does anybody have any questions they'd like to ask? If so, you are very welcome to type them in the chat. I think I said on there were some parts that literally you could just have been describing Samson. And I wonder if anybody else felt the same. I'm sure that they probably did. Any questions, anybody?
I can't have done that good a job. I mean, surely there. Yes, maybe I overloaded people with too much all at once and have to digest something.
I was really interested. I think the first bit, the actual the description about the so the exon skip section there and what that actually meant. I think that to me was I'm not a very good scientific person, so I kind of probably couldn't get my head around that completely.
Mm-hmm. Yep. And so, well, and just to clarify too, and I think I'm expressing this correctly. So if you're looking at the whole gene here, and we have the different exons, if you have a mutation, let's say you have a mutation at 35, where it says 35, just kind of below down into the left of the E from exons. If you have a mutation there and to the right, everything is still in place, your body will make any product that's to the right of your mutation. Okay. So for example, if you had one at 35, well, it's going to knock out anything to the left, which is basically, if you scroll down, it's all those full-length dystrophins, proteins, right? But if you look to the right, you still have the protein DP140, DP116, DP71. It will still make those products if your mutation isn't interfering with things to the right of where that mutation is. So we'll knock out anything. So if you had one at, let's say, 59, well, it would knock out basically everything to the left, which would be the full-length DP140, DP116, but you would still be making DP71, if that makes sense.
It does to me. There's some questions that have come in, James. Sorry, I'll let you answer those ones. They're more specific questions. Okay,
so it looks like one person is saying that our boy zones out when he's overwhelmed and it's so hard to get him back. any ideas? And it depends on what kind of situation it's happening in, and it depends on what you mean by zoning out. And so sometimes what will happen if kids are overwhelmed, they'll shut down. And what that means is they basically kind of become unresponsive. They might put their head down. And that's basically like a stress reaction. For other people, zoning out is more like I can pay attention for a while, but the longer I pay attention, the harder it is for me to sustain that. And eventually I can't do it anymore. And so then I might start daydreaming. I might start thinking about something else. And that's probably less like an anxiety or like a stress reaction. And it's more kind of like a boredom, or kind of like I'm tired of learning, and I'm just going to kind of think about something else. I think in either case, it kind of depends on what's happening, but in either case, you want to try to sometimes determine what aspect of it is that's either causing him to become stressed out. So maybe we're hitting him with too much information at once, and we need to kind of break things down into smaller amounts and take a break in between each one. So we're kind of more spoon feeding it rather than kind of like hitting with a fire hose. If it's more like we can pay attention for a while, but then we kind of get too tired or too bored and we're tuning out, then maybe sometimes incentivizing or creating a reward or some sort of way to help him hang in there a little bit longer, or motivate him to stay in there a little bit longer can help. If it's more just a matter of I can do the work and it's not confusing, but I can only handle doing smaller amounts of work at a time, well, then sometimes, kind of like what I'd said before, you have to break the work down into smaller chunks. And so if we have, say we have 30 math problems that we have to do, I'm just going to give him 5 at a time. So I'm not going to look at the whole thing and feel like it's too much, and then I'll kind of give up because it feels too overwhelming. So it depends. If it's more of an anxiety thing, then you might approach it one way. If it's more like a bored and sustaining effort, or just kind of, I don't like work, and so I give up after a while, you might approach it differently. It kind of depends on what's happening. As far as the next question, from what age can dyslexia symptoms show, and does support start? That's probably going to vary depending on how things are typically approached in the UK. So what I would say is you can see the signs of dyslexia usually by year 1. Sometimes even by preschool, if they're having a hard time learning letter names and letter sounds. But usually, like, that's, at least in the US, they start teaching literacy now in kindergarten, which would be year 1. And you can see signs of it. Basically, they're having difficulty sounding words out. They're not able to do that. They're guessing. They just don't know. You can see signs of that, and intervention can start at that time. The way that you provide intervention for dyslexia is with a lot of intensive, repetitive phonics instruction, like over and over and over again, more than what they typically provide in the regular classroom. So if you have a kid who doesn't have dyslexia, if you expose them to a new letter sound combination, if you expose it to them maybe 6 to 7 times, most kids usually have it. It takes them a while maybe to develop automaticity in that connection, but they usually have it. If you have a kid with dyslexia, you have to expose them to it probably between 50 to 70 times before it really truly sinks in. So a lot of it is a matter of more repetition in that process. The problem is, though, is that tests, like formal testing to evaluate dyslexia, the younger the kid is, the less sensitive the tests are. And so the younger they are, the higher rate of false negatives, which means you may do okay on the test, but still actually have dyslexia or have problems with reading. So sometimes with younger kids, we may not get too caught up in having to do testing, and we may instead just say, hey, we're struggling, whether it's formally called dyslexia or not, we need some extra phonics, we need some extra help with this to catch these reading skills up. The older kids get, the more accurate the tests are. And so schools are more and more likely to do actual testing probably by the time they're in year 4, so 3rd grade in the US. At that point, the test, there's a better accuracy ratio. However, what I sometimes see here is that because of that, schools will sometimes say, we're not going to make any determination until the child is in 3rd grade, which is really kind of a misinterpretation of the tests. Rather than kind of saying, well, we're going to do testing now in 1st grade, and we might get a negative result, but there's still a problem and we need to give help anyway. Now they're saying, well, we're not even going to do any testing until 3rd grade when we know it's going to be accurate. But then the problem is you missed all those years of intervention. And research clearly shows that the earlier you get intervention for dyslexia, the more likely you are to be able to fix it. So, sorry, it was kind of a long answer to a short question, but it kind of depends. But the earlier, the better. And you can start working on it early. You don't have to wait. And so somebody asked, said their son was offered medication for ADHD, but they declined because they didn't want to slow him down. It depends on what you mean by slow him down. In general, what it does is it helps kids be more alert and more in control. They're better at putting the brakes on and stopping themselves. And in some cases, that might make them less talkative. The medicine shouldn't be, though, where it makes them lethargic. And it shouldn't be where it makes them where they're not interacting, where they're not communicating, where they're just kind of like a vegetable or a zombie or something like that. And I see that sometimes, but that's really more a problem of the dosage, like they're being over medicated. And so it's really important in the situation of medication to really take time to really carefully fine tune things to the point where we're getting some benefit, we're getting improved attention and focus and concentration and motivation to do schoolwork. We're better at, if needed, staying in our seat and putting, not talking when we need to not talk, yet still talking when we should be talking. Better self-regulation in that regard. But it shouldn't be where it just kind of in a blanket sense kind of slows them down. If that is happening, then you need to revisit that and possibly adjust medication. But most people, if they're putting due diligence into really working with the doctor and the doctor knows what they're doing, most people can find something where you can find a good balance. Now, I would say that anybody who takes the medication, it can make them more quiet and more serious, more like intent. But it shouldn't be, like I said before, it shouldn't be drastic. And they should still be interactive and engaged. I do see some situations, though, where what happens is it brings things down to a normal level, but people aren't used to that, and it kind of weirds them out. But it's more a contrast. It's not because it's necessarily kind of, had this blanket negative effect on them. And so there was a year or two ago, it's more than that now, a few years ago, I was talking to a family who they had this problem, and they tried medicine, and they contacted me and they said, we tried the medicine, but we stopped giving it to him because it turned him into a zombie. It made him too quiet. And I said, okay, I understand. Tell me what happened. And they said, well, we'd be driving around in the car somewhere, and instead of singing at the top of his lungs, kicking the seat constantly and fighting with his brother next to him, he would sit quietly and look out the window at what we were driving by. And I said, well, that's what most kids do. And they're like, oh, you're right. Oh my gosh. Never. So sometimes it's a matter of perspective. And it shouldn't be this blanket kind of sedating effect. And if it is, then some work needs to be done to find a better fit. Because it can help kids put the brakes on, sit still, be in control, not annoy other people, not constantly blurting things out, not getting in trouble all the time, which certainly can have an impact on self-esteem and mood and that sort of thing. And then also there's some academic benefits to that too. So the two things that are the strongest predictors of academic outcome, just in general with anybody, are IQ and self-regulation. Clearly, time and time again, research studies show those are the two biggest factors. Not a whole lot we can do about IQ, but sometimes medicine can help with the self-regulation, and that can go a long way towards having success socially, in school, self-esteem, all that sort of stuff. So again, I don't want to oversell it and say it's the perfect fix to everything, but it can help. Let's see. So the next question is, would a deletion of 44 affect DP 140? And it depends, because I don't know, because the promoter is right in between 44 and 45. And so it would depend on exactly, because there's some introns and stuff there too. And I don't know enough about it to be more specific, but it would depend. You'd have to kind of look at the sub-exon level to determine, I believe, to determine if that actually affected DP 140, because you're right, kind of, you're in the middle there. So it's possible that it didn't, but it also equally possible that it could have, but you'd have to look more carefully at the sub-exon level to figure that out. Then if somebody had a deletion of 75 and 76, you would not have any DP. Yes, that is, I believe that's correct. Because that's kind of, again, wherever you take the mutation point, it basically kind of wipes out everything to the left of it. That's my understanding. So I could be wrong in that, but that's my high school level biology recollection. And then there's another family said, we appear to have a large deletion, 13 through 41, but it still allows most proteins to be made. So does the size of the deletion make a big difference, or it's more a case of where it is? Good question. And my understanding is it's probably more of a difference. It depends on where it is rather than the size of it, unless the size, knocks out one of those smaller isoforms. I think what we probably know the least about is people who have a large deletion, but are still actually making a full-length dystrophin protein. So they're like considered in frame, which would normally be Becker, but they have a Duchenne phenotype. Now, I would say that, there's a lot we don't know about this, but it looks like the rate of learning and behavior problems in Becker is the same as, if not more problematic than Duchenne. So what that means exactly, I'm not sure, but I would say that probably kind of goes along with that question, in the sense that it probably depends more where it is and less so kind of on how much you're disrupting the full-length dystrophin. And somebody else asked, we have a lot of problems with screaming and have tried everything. And I'm assuming you're talking about the child screaming, not the parents screaming, because different approaches, but sometimes it's both in that sort of situation. It is at my house.
Especially at the moment.
Yeah, exactly. And so what I would say is it depends on in what context the screaming is happening. If it's screaming when mad, that's one approach. If it's screaming like when excited or for random reasons, that's probably more related to impulsivity. And so the question has to be asked, okay, is that something we can target, like with behavior modification techniques? If so, there's kind of systematic ways to approach that. We probably don't have time to get into it like this, or get into it right now, but essentially you set up a system that tries to reduce that by incentivizing things, maybe setting up expectations for when it can and cannot happen. If it's part of a general kind of more broad problem with impulsivity, then that may be hard for the child to control, because by definition, when something is impulsive, it happens pre-thought, it happens without thinking about it. And so it can be hard to address those behaviors if there's a lot of impulsivity going on. And in some situations, sometimes some medicine can help if we're having a lot of impulsivity in a broad sense. If it's not kind of part of a broad pattern, but it's kind of more here and there and it's kind of annoying, well, then maybe behavioral strategies would be something to think about, or a combination of the two. So, any other questions or? So there's a question, is there an age when children with DMD typically become unable to keep up with their classmates, and roughly when is it? Is this physically or academically? academically. Not typically, no. There isn't kind of like a set pattern. There's a wide range of variability. Some kids don't have any difficulty keeping up. Some kids are advanced. Some kids struggle right from the get-go and continue to struggle through school. Other kids, they may do well initially, but then as academic expectations go up, then sometimes they can have some weaknesses that before weren't really getting in the way, but can kind of become more noticeable as the expectations increase. But there isn't really any kind of set time. I would say that just in general, probably the years that I see as more problematic are, and again, this is unique to the US school system, so I don't know to what extent this is reflected in the UK, but here in third grade, which would be year 4 in the UK, I believe, there's a big shift in terms of expectations that are put on the kid for being responsible, for keeping track of their own stuff, for taking their own initiative. And so sometimes that can be a big year where in the earlier years, the teacher's been doing a lot of that for the student, but then there's a shift where they expect the student to take more responsibility for that stuff. And if the child has weaknesses in things like short-term memory or planning or organization, or if there's any kind of academic weaknesses, and sometimes those can become magnified. The other big transition year is from elementary school to junior high, which typically here in the US in primary school, you'll have 1 or 2 teachers the whole day. When you shift to junior high, you have 7 to 8 teachers, and all of the teachers have 150 students. And so they're not there kind of coaching you along every step of the way. And so again, there's a lot more responsibility that's put on the student for keeping track of things and managing their time and taking the initiative. And if they have questions, they have to ask the teacher. The teacher's not going to kind of follow up with them if they don't. And so big shifts like that can be kind of major, can be years that cause a lot of difficulty because there's that big shift in expectation. So I don't know to what extent the UK school system is the same, but I suspect there's probably kind of some milestone years like that. Any other questions? All righty. Well, thank you all for letting me share and be a part of this. And hopefully everybody stays healthy and safe.
Thank you so much. Really brilliant, James. Thank you. And thank you to everybody for coming on as well. I don't know if everyone, like myself, have had children in the background. So thank you. Really, really appreciate it.
Definitely. And yeah, if anybody has any questions, you know, maybe if we have a conference again at some point, I'll be there. Things are weird right now. Best of luck to everybody, and I'll talk to you in the future.
Thank you, and just thank you so much to James for giving up his time for us tonight. I think everybody got a lot out of it. Certainly I have, so thank you very much. And just to everybody who's joined us, and do watch your inboxes for the feedback forms that'll be coming. We'd love to get those back and hear what you thought of tonight. And just to let you know that we're planning a lot more hopefully a lot more webinars to come. We're busy working away, so you'll see us again very, very soon. Please keep an eye out on our social media, subscribe to our newsletter, and get the first hot off the press news when the next one's to come. Hopefully not too long. Thank you, everyone.
Take care.
James.
You got it. Bye.
Bye.